Okay, we'll get rolling here then. So let's move on to the foot and ankle. Okay, so we'll talk a little bit about technical. I won't go much into technical here. Some of the anatomy, anomalies, and then we'll later go into tendons, ligaments, bones, and inflammatory disease. Let's see, Ashley, why don't you take this case? Patient with foot pain.
Oh, all right. So we're looking at I think this is the first metatarsal, beginning of the sesamoid bones. We see a focal increased fluid along the dorsal aspect of the tarsal.
Through
It's
here.
kind of expanding out there. Yeah. Are we just looking at a bursitis or a joint effusion?
Okay. Well, they gave contrast because they were also concerned about whether the patient might have a mass, and this is what the post-contrast study looked like.
Okay, so we have
Wait a second. Hold it. Okay, so here
It's
we
a little
have
brighter, isn't it?
T1 pre. Here's the T1 fat sat post. Here, coming back again. So what do you think this lesion is?
I don't think you can compare these two, though.
Okay, so the concern was whether okay.
Well, I mean, just
yeah, I presented this incorrectly. So the patient had pain and also a palpable mass, and here are the first two sequences. And so you picked this up and you thought it was fluid.
yeah, because I wouldn't compare it the post contrast T1 fat on fat sat T1.
Okay, and then so we got we also have a T1 pre, and when we look at the T1 pre, we can see that it's actually bright on the T1 pre as before. And this is fairly typical of these cysts. They can have high protein content with them. In fact, often the fluid is very viscous, and they can be bright on T1 fat sat images. So again, pointing out that this was not a mass, this was not an enhancing mass, this was a non-enhancing mass. But if you just look, as I've said previously, I just want to emphasize it again, if you use a T1 non-fat suppressed and compare it to T1 fat suppressed post, you're going to have a lot of false positives. So just want to, again, make people careful of that. I still see it all the time.
I can hear you.
Yeah, I lost you as well.
You can't hear me now?
I can hear you now.
Now we can.
You can. I wonder what that's all about. Okay, well, thanks. Okay, so that's just a high protein content cyst. Another big problem in the foot and ankle that I see all the time are definitions of the plane of the foot. There's no problem with the sagittal plane, but where there's a problem is the axial plane and the coronal planes. Now, the axial plane, by definition, using the standard anatomic human, would be planes through the body that are parallel to the floor. And then the coronal plane, by definition, in the standard anatomic man, would be in the plane. If you're standing back up against the wall, it would be a plane parallel to the wall. But many radiologists and a lot of techs will confuse the axial and coronal planes in the foot because they think of the axial plane as a short axis along the bones, but that's really incorrect, and it leads to a lot of problems. So, and when you get into your practice, you gotta make sure that the terminology is used appropriately. So you should, if you use the axial plane, you should make sure it fits with the standard anatomic definition of the axial plane, which would be along the axis of the long bones of the foot. Or you should just, in the foot, you should just talk about long axis and short axis with respect to the metatarsal so there's not a confusion. I generally find that about half of radiology groups use this correctly and about half don't, but it can cause a lot of confusion. And we still have problems with labeling a lot of the studies in RadNet when we have technologists who are part-time or per diem technologists who spend most of their time imaging for other radiology groups, and they come in and image for us, and they incorrectly label the planes of the foot. But this can be a significant problem, and in your practices, you'll have to make sure how you're going to deal with this.
Why has this been going on since MRI has been invented?
Yeah, it's actually been going on since CT was invented.
Well, I don't remember that, John. That's too long.
No, you were around for that too. So anyway, it's still a problem, and I still see a lot of radiologists using inappropriate terminology here, but I just want everybody to be aware of that. Okay. So this would be the axial plane, whereas a lot of radiologists would call it the coronal plane. So Michael, this patient had foot pain. What do you think is going on here?
Okay, so first image T1 axial. We can see degenerative changes at the first MTP joint. First, then moving on to the second ray. Assume that's not cut. Have they had is that just a slice collection, or have they actually had like a amputation of that second digit?
No surgery.
Okay, because it looks like it's going a different direction between the first and the third. There's kind of increased signal surrounding that, kind of the in between the second and third metatarsal MTP joints, kind of in the soft tissues.
Okay.
But I don't really see anything there on the T1 axial.
Okay, so what do you think's going on here?
Are there not more images, or?
This is a common finding in foot imaging. But just based upon these images, what would you call this?
Well, I mean, like I said, there's degenerative changes, like a pretty marked degenerative changes first MTP joint.
Okay, I'll give you the first MTP joint. What about the rest of the findings you described? What are they caused by?
Like the soft tissue?
Well, you described an abnormal signal intensity within the proximal phalanx of the second ray, and also the adjacent soft tissues. So what's going on there?
Well, I guess one thing you worry about, like if they're diabetic and ulceration, but there's no really signal difference in that T1 proximal phalanx.
That's
important. I don't know, it's contusion, stress reaction, chronic stress reaction, that type of thing. I don't know if what I'm seeing.
So what would you do next to figure out what's going on here?
Well, I'd want to scroll through it because I don't really see the second MTP joint.
If you scroll through it, you'll see the same thing on all the other images.
Well, you do see a bunion, but that's beside the point, isn't it, John?
Right. So those signal changes you would see on all the images. If you scroll
is the second MTP joint intact and the distal second metatarsal? Because I don't really see it that well.
The phalanges are normal.
Okay, so just the direction it's going, is this like sublux, like a hammer toe type issue?
What's causing the hammer toe wouldn't cause the signal changes you described. What's causing the signal changes you described?
If you have like abnormal pressure changes like on that, phalanx.
Okay, well, we decided to get stir images, and here's stir images through that area.
Oh yeah, I mean you always compare it to the stirs to make. Well, you just get abnormal. You get coil artifact, incomplete fat saturation, so you always have to compare the PDs or the T2 fat sats with stirs, which are going to get more homogeneous fat saturation.
Okay, so this is inhomogeneous fat suppression, which is a common problem with fat suppressed techniques. Why is that, especially in the foot? Why is that a problem? Why is it so common in the foot?
I assume because that's where, it's like at the edge of the plane or the coil.
Yeah, it could be due to the coil. Yeah. What happens in the extremities like this is you get variation in the field strength. And the fat suppressed technique is at a given frequency, which assumes that the water nuclei are at a uniform field. If the actual magnetic field at the location of the water molecules is different from what you assume, then you may either suppress it or not suppress it, if it's inside the SAT band or not. And so this is a common problem of field inhomogeneity that we see in the foot and ankle. And that's the reason in our foot and ankle protocols, we always include a stir sequence in one of the planes, because the stir uses fat suppression not based upon frequency. And therefore, you don't get abnormalities within the fat suppression on stir due to field inhomogeneities. The last fellows haven't wanted a physics talks, but if we decide to do the physics talks, we could go through that in detail as to what's happening. So this is all. This is basically a normal area with some mild degenerative changes, but that was all artifact from inhomogeneous magnetic fields.
And so was the bunion.
Okay. Yeah. Okay. And then one of the reasons we do fat suppressed images, PD fat sats, is that we're able to get better signal to noise than we can with a stir. And by doing that, it allows us to get higher spatial resolution, as we can see here. So we like to use PD fat sats for most of our fat suppressed images because the image quality is better, as we can see here. Typically, what I like to do is do the stir in the sagittal plane, because that's a plane that we usually have the largest field of view, because the foot and ankle are long in the anterior posterior direction, but they're not so wide in the lateral direction. And then I like to use the PD fat sats in the coronal plane, because then we have less of a volume of anatomy in the coronal plane and less likely to have inhomogeneous fat suppression because of that. And then some people call arthrography. Fortunately, we finally pretty much gotten rid of arthrography in the ankle. I don't find it very helpful. So in the foot and ankle, there are a lot of anomalous and anatomic findings, and some of these are significant, and some of them are just kind of interesting. So let's go through some of these. Yeah. So Ashu, what do you see here?
Here you can see a prominent peroneal tubercle, and I think there's some tendinosis of the peroneus. Is that the peroneus longus?
Yeah. So the peroneal tubercle is a bony projection which is congenital in the distal aspect of the calcaneus on the lateral side, which separates the peroneus brevis from the peroneus longus. And what happens is you can get rubbing of the peroneus longus on this hard bony projection here and get tendinosis and tearing of the longus tendon. So it's a risk factor for the disease of the peroneus longus. There are two projections here that can be an issue. One is the peroneal tubercle, which is always between the two tendons. And then there's also another one back here at the insertion of one of the muscles, which is posterior to the peroneus longus, which is a normal finding and is not really a common cause of pathology. So if you see a peroneal tubercle, you need to make sure that it's between the two tendons before you're concerned that it's pathologic. Here's the coronal plane where we see the peroneal tubercle and some tendinosis on the longus tendon due to that. Now, the retrotrochlear eminence is back here and is a normal finding, not associated with pathology. I have seen a number of radiologists call retrotrochlear eminences peroneal tubercles, and that's a pretty significant mistake. And we'll talk about more disease here, I think, later and what to do about it. Okay, and here's just an example of the retrotrochlear eminence back here. It's behind the peroneus longus, and there's the tendon attaching, and it's just a little bony prominence from the peroneal retinaculum attachment. Okay, Michael, what do you think of this case?
Okay. So I don't know if it looks like there's kind of abnormal configuration of how the calcaneus is aligned with, the navicular over there. Like they.
Actually, here's the navicular up here.
Yeah.
And this is the
like
cuboid.
No, I'm not talking about articulating with each other. I'm just wondering, because the navicular axis compared to the calcaneal axis looks a little weird. I don't know if it's just the angle.
Oh, yeah, I don't know. That's.
Okay. And then I do notice that there's a type 2 os navicularis, which I think is non-edematous.
Well, yeah.
But I'd want a fluid-sensitive single.
So it's accessory navicular bones. I think we'll go through the grades here. This is just a cornuate process, which would be a type 3 on a CT scan of the. Accessory navicular bones. There's a type 1, which is small, completely encircled by tendon. Type 2 is larger and actually has a synchondrosis, which articulates also with the navicular. And then the type 3 is just a projection of the navicular medially and posteriorly, which is called a cornuate shape. And these can be a cause of significant symptoms. And we'll talk more about that when we get to pathology later. But there are many other ossicles which have been described in the literature. Most of these have been described as being congenital variants, of which a lot of them are. Some of them I don't believe are congenital variants. I think some of them are pathologic, and we'll talk about the pathologic ones. Okay, let's see. Ashu, what do you think is going on here? It's a little hard to see. Let me show a couple of images. Well, what do you think that might be? Oh, sorry about that. I'll say anyway. This is actually another thing that you can get is a bipartite first cuneiform, which we can see here. Examples. And here is just a bipartite first cuneiform. And this is thought to be a congenital variant. Occasionally you can get degenerative changes due to motion at this joint space, in which case they may be a cause of symptoms. Here's another example. I guess occasionally these may be fractures as well, but most of these are thought to be congenital. Okay, Ashley, why don't you take this one?
I think this is just a really, it looks like it's continuous with the posterior talus, so it's just a prominence data process.
Yeah, so this is prominence data process, and with a little bit some signal changes here, so you can see why these very large data processes can produce posterior bony impingement in the ankle, and we'll talk about those later as well. These can be various sizes, and as you all already know, you can get fractures at the base of these data processes and end up with os trigonum back here, which is usually described as a congenital variant, though I believe most of those are probably old fractures at the base of the steata process. And this is just an example of an os trigonum. You can see here there's some degenerative disease due to the articulation of the os trigonum with the posterior talus. And you can also see how it really looks like it might be a fracture and the previous possible continuity of the posterior talus with the steata process.
Superior talus also has an abnormality.
Yeah, and here is an osteophyte here.
Neck, yeah.
We'll talk about that later too. These are typically acquired lesions, and we'll discuss that when we talk about anterior impingement. Okay, Michael, what do you think of this case?
Okay, so this is going to be an os peroneus within the peroneus longus tendon.
Yeah, so this is down by the cuboid. Again, it's commonly described as a congenital variant. This case has a little bit of edema in it. Let me just see here. Ashu, what do you think in this case? This is sagittal ligament. This is the base of the fifth.
Is this an os vesalium pedis?
No,
Or-
actually, what we're seeing right in here, this is, just let you know, this is the distal part of the peroneus longus tendon in through here. And the patient had pain after twisting injury of the foot on the lateral aspect of the foot near the base of the fifth.
Oh, is it? Okay, partial tear.
So this is actually a partial tear of the peroneus longus. This was back in 2000. The patient came back 4 years later, and what do you see in this same location?
I see avulsion of the, is that the cuboid, or is that just ossification?
No, nothing attaches to the cuboid here. This
Oh,
is
okay,
an
is that
os peroneum.
peroneum? Okay.
Yeah,
Os peroneum,
within the peroneus longus, actually, and then this just shows that previously you had an area of a partial tear, and when that healed, it healed with an ossicle formation within the tendon. And I think this is the way most peroneal ossicles developed, is they're secondary to prior injury to the tendons. We see this kind of mechanism other locations. We've already seen it in the ulnar collateral ligament of the elbow, where a pretty large percentage of Major League Baseball pitchers have ossicles in the ulnar collateral ligament, and it's almost never seen in the general population. And I think these are responses the body loves to heal with bone formation, and these I think are typically residual of partial tears of tendons.
This is not a complete avulsion then.
No, there's nothing avulsed here. This is all within the body.
No, I mean,
of the.
I understand.
Yeah.
It's a tear, but it's not a complete tear.
Correct. It's a partial tear. It's a residual of a partial tear. Right.
Right.
Okay. Let's see, Michael.
So is this not kind of like, similar finding as in the region of the within the region of the peroneal tendon with this smooth corticated bony fragment?
Yeah, so this is a bipartite.
I guess, yeah, it's like we can see on that short axis, it has two longitudinal corticated areas.
Yeah, so it's corticated here. They either developed as two, or it's an old injury, but there's nothing acute here, and no edema. Okay. Ashio.
Okay, we're looking at two radiographs here. I do see a well-corticated fragment off of the lateral malleolus, just inferior to the lateral malleolus there. Right. Without known trauma, still thinking about a prior avulsion fracture that's well-corticated, maybe remote.
Not in a kid, no.
Oh, yeah.
I think that's congenital.
Okay.
Yeah, it's called an os fibulare, and maybe it's congenital or maybe it's an old injury. I don't think we can tell on these studies. We certainly don't see anything that looks like an acute injury, but an os fibulare has been described in the literature as a congenital lesion. Okay, Michael.
All right, so there's this well-corticated non-denubitus bony fragment kind of on the superior aspect of the calcaneal cuboid articulation, and there's adjacent degenerative changes of the calcaneal cuboid with significant subchondral marrow edema, sclerosis.
Okay, well, what do you think's caused this?
I don't know if this is a specific ossicle. I don't know its name. I don't know if it's just status post degeneration. It looks too big. I'm not sure what this is called.
Yeah, it doesn't really have a name. We can enter calcaneal ossicles, what I call these. They're not uncommonly seen. This is a very large one. Usually they're much smaller. I think a lot of these are old fractures of the anterior process of the calcaneus, but some of them I think are probably congenital. And you really look for associated bone edema and degenerative changes to correlate with symptoms.
Is the rest of the ankle normal? I mean, the foot?
No, there's a lot of degenerative disease here.
Yeah, there's a lot of whatever.
Yeah. And then here's a more typical anterior calcaneal ossicle, which is smaller here. This is the navicular. This is the anterior process of the calcaneus. Some of these may be congenital. Some of them may be little fractures here of the anterior process. This is called an os calcaneus secundarius. Here's another view on plain films of that. Okay, let's see. Ashu, are you next?
Yes. So 37-year-old male with intermittent foot pain. We have bilateral foot x-rays here. Trying to look at maybe the lateral aspect of the fifth metatarsal, proximal fifth metatarsal.
Here?
No, sorry, the proximal. It could
Down
be normal.
Here?
Yeah. Is there a small ossicle there, I guess, of the fifth metatarsal? I mean, yeah.
Okay.
Nothing really. Oh, yeah. It's a small ossicle at that. Oh, I didn't even see that on the x-ray.
Yeah. These are called os intermetatarsals.
Oh, there it is.
In between the metatarsal bones.
Yeah.
And they're also considered congenital. This one's nice and rounded. It doesn't really look like it's come off of anything. It's the same structure here.
I think that one it was barely visualized on the radiograph. I could barely see it.
Yeah. And they're not that uncommon if you really look for them. But generally they're not considered of much clinical significance. Okay, Michael?
John,
Yes.
unless there is edema around these ossicles or some kind of inflammatory changes, you have to consider that that's not the area of injury.
Right, unless there's a marker right over it. I agree. I don't think that last one was. I think that was just a normal variant.
Okay. So on this, so you showed the zoomed in image. So we can see like right kind of overlapping with the medial cuneiform. There's this tiny little corticated bone fragment. Yeah, right there.
Right there. There's a little.
And there's also a type 3 naviculare, correct?
Yeah, right. I think right here, exactly.
Yeah. That was the first thing I saw, but then you showed the zoomed in.
Right.
And then I noticed that there's that tiny little, so it's actually on the dorsal aspect of that first TMT joint.
Okay, there's the MR.
And there's significant marrow edema in that medial cuneiform and that little ossicle. So I don't know if this is ossicle secondary to prior trauma with degenerative change or what the, the order of pathology is, but there's, significant degenerative change there.
So the first one that we saw was asymptomatic. This is a painful os intermetatarsum. So, and it's, probably abnormal trauma. And as it says here, these can come in a lot of different sizes and shapes. But as John said, looking for edema on the MR scan is probably the best way we can help differentiate between symptomatic or non-symptomatic. Yeah, and then this just shows some of the nerves. This just shows the peroneal nerve coming down on the lateral aspect over by the fibular head with its different branches. And obviously, this is probably the most common neuropathy of the leg, which is typically a foot drop. And it's some people say if you expose it on surgery and you sneeze on it, you can get a peroneal neuropathy. So it's a structure that the surgeons are very wary of.
Usually it's from crossing one's leg.
Right.
My accountant has that condition.
Interesting.
And you have to be skinny to do that. Because women cross their legs, I rarely ever see that in women. But he's a male and he's very skinny. He's a diabetic who really follows the regimen
Yeah.
of low calories, and but his is coming back, so he's improving. What you get is you get numbness the dorsum of the foot, and that's the clue that it's not from the back. It's a common peroneal nerve.
Yeah. And then here we can see that the distal branches come, just as John said, into the dorsum of the foot and ankle.
Yeah, and the healing is usually the numbness goes away, and then the function comes back.
Okay.
But that's the usual cause, unless you're talking about fractures, which is another one, of course.
Yeah.
Crossing one's legs, don't do it.
Okay, here we can just see two more ossicles. This is an os subtibialis and a calcaneus secundarius. Okay. Let's see, Ashley, what do you think of this case?
Just proximal to the fifth metatarsal base, there is some calcification, maybe an ossicle there. It's pretty big, and there's fractures of the fourth metatarsal proximally, and I don't know if that might, yeah, it looks like the fifth metatarsal is also fractured. Looks like a lot of metatarsal fracture, a lot of trauma here.
Yeah. So you can see a lot of trauma here. This is actually an os, the soleus in this location. It's not within the peroneus longus tendon, and it's actually fractured along with the other bones that were fractured there. Okay, chronic medial ankle pain, Michael.
Okay, so we see this well-corticated bony fragment adjacent to the kind of inferior medial talus, and there's edema across like this synchondrosis with this ossicle. So that could be a pain generator. And this looks like it's more in posterior aspect of the medial talus.
Well, what is this?
Well, it looks like kind of like a stiata process in a way.
Well, but you're.
But then there's this little
which
bony.
Side of the ankle? Which side of the ankle are you on here?
What side of the ankle? This is the medial.
Okay, so we're on the medial side of the ankle, and what structures do you have here and here? Often another one would be up there on the medial inferior.
So this is just going to be like it's going to be just like a fibrous coalition, talocalcaneal.
Yeah. So this the first thing I would think about in this case would be to be a coalition in this location. But then what it turned out is that this actually was not part of the calcaneus, and this was actually an ossicle, an abnormal ossicle in this location, and it must have been developmental because this whole posterior there was deformity of this. If I just saw these images, I would think that this would be the posterior facet of the subtalar joint space, but this turned out to be an ossicle here and not the calcaneus. So it's just a situation where there could be old trauma, but it was probably congenital, producing a lot of degenerative disease associated with that posterior subtalar joint space. But just looking at this, my first thought would be that it would be a fibrous coalition.
Mine too, but I would look for other pathology, or congenital pathology.
Yeah. Okay, Ashu.
This is a 5-year-old male. Looking at this, looks like pretty bad pes planus deformity, but the talus looks like it's, oh wow, yeah, polydactyly. It has a lot of
Right.
metatarsals there.
Yeah, a lot of bones.
He should go swimming.
Yeah, Probably be an Olympic swimming athlete.
But it almost looks like there is a vertical talus too, almost a vertical talus.
I think there is plus minus.
Obviously,
Yes,
it's a flat foot, but that talus is a little.
I think it's abnormal. I agree.
You don't see these very often, but in Cincinnati, my chief used to think a lot of these were vertical, and or everybody had a flat foot in his opinion.
Yeah, I think this is a real one.
I think he wasn't allowed in the army because of his flat feet. And he was upset about flat feet.
Oh, he got out of World War II.
World War II, yeah, and he was upset about it, I think. He never talked about it, but I think that's probably what it was.
Interesting.
He made me his doctor, so, but he's deceased, so it's okay to talk about it.
Okay. So let's talk about coalition, because that's a common problem in the foot and ankle. Michael, what do you think of this case?
Okay, so this is, I guess, is what what the other case is almost looking like, but now we can see the posterior aspect of the lateral calcaneal facet and talus are extending together, and there's kind of a bright signal across this. It doesn't look like there's bony bridging, so this is probably fibrous talocalcaneal coalition.
Well, probably on the medial side. And this, for the post, and this, see how irregular there is a joint space there, but there's bony hypertrophic bone formation here, very irregular margins of the bone, and this is very characteristic of a fibrous coalition. And the subtalar joint is one of the most common locations for fibrous coalition.
Fibrous, isn't it, John? And ergo you have inflammation and stress in the area.
Yeah, a lot of abnormal stress leads to the hypertrophic bone formation, right?
Yeah.
And this abnormal stress transfers through the subtalar joint space. Okay, Ashu.
I see the navicular, there's a fibrous coalition there between the navicular and I'm guessing the anterior facet of the calcaneus, so it's a calcaneal navicular.
Yeah, the anterior process of the calcaneus, that's right. So that's another common location for coalition, in this case fibrous. Here's another, this is the anterior process of the calcaneus, the navicular bone. See how irregular the margins are here, and some bone edema here in the navicular. The navicular is a little bit abnormal in shape. This is another typical appearance of a fibrous coalition. Leads to an abnormal stress pattern and chronic ankle pain in these individuals. Okay, now this is a more severe example. Here is all across the navicular, an abnormal shaped navicular. Here's an abnormal anterior process of the calcaneus. We see a lot of edema on the stir images through there. Here we can see a little bit of fragmentation of the adjacent bones going all the way across that coalition. There's that fibrous coalition. This is the kind of the biggest one I've seen in through here, going all the way across, and we can see the edema pattern. So that was a calcaneal navicular coalition. The patient then had surgery, and actually they resected the fibrous coalition in through here. And we can see these are the postoperative changes. This patient still went on and didn't do great, but they had some relief of pain, but they were not able to go back to volleyball, which is what she wanted to do, even after the surgery.
We usually put fat in the area we excise, and maybe that she was off weight bearing, not long enough, or something. Fat is very preventive of a recurrence of healing.
Good.
But that's unfortunate.
Right. Michael, what do you think of this one?
Okay, so there's chronic foot and ankle pain. There's abnormal appearance of the anterior talus with flattening and osteophytes and kind of bony remodeling. And yeah, I don't see any action. And that's actually articulated directly with the cuneiform, so that what I'm seeing is actually the navicular bone, complete bony coalition with the talus.
Yeah. Right, so this is a bony coalition, that's right. So this would have been the navicular here. This should be a talus, and the two are so this is a bony coalition or fusion between them. Right. And here we can see a fibrous coalition there. Okay. Ashu, what do you think of this case?
Looking at the second image, I think there's osseous coalition of the talus and calcaneus.
Okay. And then what's happening here?
Looks like there's. Is that just?
This is the navicular here.
Wow, it's just elongated.
Well, and this is the anterior process of the calcaneus over there.
Okay. So there's another osseous coalition of the navicular and calcaneus superimposed. Right. Wow, there's a lot of coalitions.
Yeah. So you have to keep looking because if one area you have a coalition, if it's congenital, you may have other areas, or if it's acquired, like in rheumatoid arthritis, you can often have multiple coalitions as well. And if they decide that they do need to treat it, it's important to recognize where all the coalitions are, because they may need to treat all of them. Okay. Michael.
Okay, so here we see abnormal bony bridging between the distal calcaneus and the cuboid. So this would be bony coalition. And then we see secondary degenerative changes occurring in the subtalar joint as well.
Yeah.
Like pretty marked secondary degenerative changes.
And a lot of lateral impingement here. So one of the problems with these chronic coalitions is it changes the stress pattern across all the other joints of the ankle, and commonly will then lead to degenerative disease over areas where you have abnormal stress patterns.
Yeah, and so in this one, I guess we have cystic change in that lateral talar process, which is now close to articulating with calcaneus and effacement of the sinus tarsi.
Yeah.
The most common is the talonavicular, and the treatment for a lot of these is because you get multiple coalitions, is triple arthrodesis. In other words, you fuse the three bones, talus to the navicular, talus to the calcaneus, and the cuboid. And that's the treatment for most of these. And that works out pretty well. Triple arthrodesis is a very common procedure in orthopedics of the foot.
Okay. Ashu, what do you think of this case?
Okay, so we have two coronal views. There's definitely thickening of that and shortening of that first metatarsal.
These aren't coronal.
Oh, sorry, axials. Oh, man. So there is thickening and shortening of that first metatarsal.
Yeah, it has a funny appearance here, doesn't it?
Yeah, almost like there's a bipartite or.
Yeah, it looks almost like the growth plate's in the wrong place.
Yeah.
Yeah.
It's like it's flipped.
This is called an epiphyseal or metatarsal bracket, and it's a congenital abnormality where the growth plate doesn't develop properly in the metaphysis, and you get abnormal bone growth and secondary deformity from that, called an epiphyseal bracket. Okay, Michael.
Okay, 17-year-old female with pain for 7 months, no trauma, rule out coalition. So we have this large, mildly edematous spur extending off the superior anterior talus. There's also the edema in the talar neck. And there's some abnormal edema and bony irregularity of the dorsal navicular.
That's not a spur.
Okay. So this is.
It doesn't look like there's any pathology going on there. So it's part of the talus. It's a congenital thing, I think. Don't you, John?
Well, I think there are people who consider these congenital. It's called a Talar beak. We saw a little bit of one earlier that you pointed out, John, which was an
that would be more proximal, and that kisses the distal tibia. This one does not. This one goes the opposite direction.
Right. So
and that's the difference.
Yeah, these bony projections here are called Talar beak, and what should that make you look for, Michael?
We see the Talar beak in the setting of coalition.
Yeah, exactly. So you've got to look for correlation. And so you look other areas. Here we can also see that there's
lateral hindfoot impingement.
Yeah, some impingement there. And we've got bone edema posteriorly there. We go to the coronal images, we can start seeing some degenerative change along here. This patient did not have correlation, but the patient had the abnormal, had a lot of abnormal bone marrow edema and impingement here. And this is called an anterior lateral facet of the talus. And it's generally associated with impingement between the talus and the calcaneus. And with that, you get abnormal force transfers through the ankle, a lot like a correlation, and that can produce this hypertrophic bone formation here called a Talar beak. So so there are several causes of Talar beak. The first thing, and if it's a young kid, you've got to look for is correlation. That's the biggest association. If they're a little bit older, you can look for these impingements down here, and a lot of these kind of subtalar impingements, if it's an older individual, like in middle age, these are typically due to adult acquired flat foot deformity, which is primarily abnormality, injury to the posterior tibialis tendon. We'll talk about that later. Or you can have an abnormal large facet involving the inferior aspect of the talus called the anterolateral facet, which then changes the force patterns because you now have a bony contact here where you shouldn't have one. And then that can also lead to a Talar beak and these other bony injury changes, which we see here. So this is all due to an abnormal anterior lateral facet of the inferior talus in this location.
It's also a very flat calcaneus, isn't it? I mean, almost. Or am I looking?
I'm not sure what you mean by that.
Right image.
Over here?
Yes, it looks kind of flat. It certainly doesn't look normal to me.
I'm not sure what you mean by flat.
Well, what I see is I don't see a cavus portion of the tail of the calcaneus inferiorly. All I see is a convexity rather than concavity. Calcaneus, John.
Okay, here's a calcaneus.
No, go right here on the right image. See where the white spots are down below. No, below. Here? Yeah, this area is convex, not concave. It should be concave, shouldn't it?
I'm not sure. You may be right.
Anyway, that doesn't look normal.
Okay.
To me, anyway. I'm obviously you've seen a lot more of these than I have.
Okay. Well, I need to look through all the images. Those were just selected images. So this was an secondary degenerative changes from an abnormal anterolateral facet of the talus. If we look in the literature about accessory anterolateral talar facets, about 80% of them will have bone edema, at least the ones that are picked up. In the calcaneus, talar bone edema, cortical thickening, cystic changes, subtalar soft tissue edema, sinus tarsi edema. So basically, this is really causing impingement of the subtalar joint space between in that location, and it's a cause of rigid, painful flat foot deformity. And I think now most people, when you get a lot of these degenerative changes, put this more into the category of adult acquired flat foot deformity. And in some papers, people think it's an congenital abnormality of the anterolateral talus of the talar facet. But I think more and more people are thinking that most of these are actually due to a degenerative disease and tendinosis of the posterior tibialis tendon, where you no longer have proper stability of the medial navicular, which leads to a progressive lateral hindfoot valgus, which can eventually lead to impingement of the calcaneus against the fibula distally.
Yeah, you see this first
deformity.
first comment is case of rigid, painful, flat foot deformity, and rigid is bad news. That's the first thing you check on people with flat feet is are they pliable and do the joints move and they're not walking on the ankle, medial malleolus, and also lateral fibula.
Yeah. And the first thing you really need to look at when you see this is also see if there are correlations, because this is also
absolutely
to correlations.
I saw my share of these in my clinic.
Yeah. Okay. Michael, what do you think of this one?
I think, is it my turn?
Okay, you do it, Asher.
Okay. All right. So 15-year-old male with ankle pain for 11 months, no trauma, X-ray was normal, non-athlete. We see a lot of edema within the angle adjacent of the calcaneus, and the lateral talar process looks pretty prominent. I don't know if it's an accessory. Yeah, there's quite a bit of edema there, and that facet, lateral talar process looks pretty big. So,
yep.
Accessory anterior lateral facet.
Another one, good. And then this is just from a study that was a cadaver study, which just shows that accessory anterior facet here. And this is in neutral position, and then in the eversion, we can see that you can get impingement here against the calcaneus, which ends up causing that eburnation and then the bone marrow edema pattern through there. So that's the accessory anterolateral facet.
Just a quick question. Could coalition come from prior, like congenital trauma that results in, osseous fusion?
Not that I know of.
Congenital, you mean trauma in uterus?
Yeah, or trauma, like very young trauma, you're 3 months old, have trauma or stress, abnormal stress.
I'm not aware of that.
I've never seen a kid do that.
I think most of the
they're born with it.
Congenital, they're born with it, and it's probably not due to trauma. It's a developmental abnormality.
And it's not taking medication or anything like that. It just happens in some families, I guess.
Okay.
I don't think it's familial either,
I don't believe so.
but it seems like in Cincinnati, everybody has some kind of anomaly.
I guess if you look for it, you'll find it.
That's the whole idea with my chief.
So in this particular paper, they when they looked carefully for anterolateral facets on X-rays, they found they could see it in 30% of the ankles, but they didn't find just the X-ray presence of the anterolateral facet to correlate well with symptoms. So I think the biggest finding is actually the bone hibernation and the bone marrow edema pattern that we see on MR to help us determine whether it's significant or not. And the important things are the bone marrow edema and the obliteration of the fat pad in the sinus tarsi. Let's see, here we can just see a fibrous correlation. Oh, let me see. Why don't we stop here and we'll start this topic. Actually, let me go through this fairly rapidly. The subtalar joint has 4 variants that have been described in the literature, and they can be, some of the variants are associated with abnormal stress patterns and degenerative disease. Here is one where we can see a lot of degenerative change here. This, I'd be very concerned, would be a fibrous coalition of the posterior facet. But if you notice this is a situation where the middle and posterior facets are continuous in this particular patient. We can also see these osteophytes which have developed here due to the abnormal stress pattern and the hibernation on the CT examination. Here we can see the marked joint space narrowing and degenerative disease of that middle facet. And so there are 4 different types of subtalar facets that have been described. The type 4 is the one most associated with abnormalities. So type 1 is the most common, where actually the anterior and middle facets are continuous, and then you have a posterior facet here. Type 2 is one we think of as the most common, where you have a posterior facet, a middle facet, and an anterior facet, but this is actually a little bit less common than having a single anterior and medial facet. And the type 4 is where all of these are connected together. That leads to constraint of the motion of the subtalar joint space, and then can lead to degenerative changes. What time is it? And then the other thing we look for is hindfoot valgus in these patients. And you can, if you draw a line parallel with the long axis of the tibia, and then a line that's parallel with the long axis of the calcaneus. And to do these, you have to look at the posterior part of the calcaneus. The anterior part can have kind of variations of its alignment, but you look posteriorly at the calcaneus, and there's an angle here that you can then define. And this would be calcaneal varus when you have the calcaneus angled laterally. And as you can see, this can produce impingement upon the distal fibula. And there are a number of causes for this. This is one. This shows the normal middle facet of the subtalar joint space. This is an abnormal facet, which is at an angle. It's not parallel to the floor. It's angled. This does not allow the middle facet to move properly, and you'll often get edema in this area. It's a lot like a fibrous correlation, but technically it's not a fibrous correlation, and you can get a lot of bone marrow edema pattern, and this can eventually also lead to hindfoot valgus. So this is just an abnormality of the plane of the subtalar joint spaces in a patient. It can act very much like fibrous or bony coalition.
What's in between, John? What's in between the 2 bones?
Here?
Yeah.
This is a diarthrodial joint, so it does have articular cartilage there, at least early on, until it becomes degenerated.
I always thought it was fibrous.
If it's fibrous, then it would be a correlation, right? Okay, why don't we stop here? And there are a few other cases that that I'll go over on Monday, and then we'll go to another topic. Okay?
Have a great weekend, everybody.
Yeah, same.
Thank you. You too.
Yep.
Dr. Cruz.